Mesothelioma is an aggressive form of cancer that develops in the mesothelium, which is the protective lining that covers many of the internal organs in the body. The most common sites for mesothelioma to develop include the pleura, peritoneum, and pericardium. Exposure to asbestos is the primary risk factor associated with developing mesothelioma. While the prognosis for mesothelioma remains poor, improvements in surgical techniques and multidisciplinary treatment approaches have led to better outcomes in properly selected patients. For epithelioid mesothelioma affecting the pleura, the current standard surgical approach is known as extended pleurectomy, decortication, EPD. In an EPD procedure, the surgeon aims to remove as much of the tumor-affected pleura as possible along with the underlying fatty tissues between the lungs, the decortication part. Removing this thicker lining tissue allows surgeons to access and directly visualize small tumor nodules or deposits that may not be seen on scans. EPD is favored over previous more limited surgical procedures as it allows for more complete tumor resection compared to prior techniques like pleurectomy or parietal pleurectomy alone. During an EPD, the surgeon will make an incision between the ribs to gain access to the chest cavity. The diaphragm is usually not entered in order to avoid complications. Under direct vision using various instruments like endoscopic staplers, ultrasound, or intraoperative pleural navigation systems, the involved parietal and visceral pleural layers lining the chest wall and covering the lungs are progressively removed. Bleeding vessels are ligated or cauterized. Lung tissue itself is spared from resection to preserve maximum lung function. Once the resection is complete, any air leaks from the lung surfaces are tested and sealed off with various sealants or allograft patches if needed. Tubes may be placed to drain fluid post-operatively. Some specialized centers now also perform a more extensive variation of EPD known as macroscopic total pleurectomy, decortication, MTPD, to achieve a more radical tumor resection. In MTPD, the technical goal is a complete removal of all grossly visible tumor with clear margins rather than just removing what is easily seen at surgery. This may potentially involve needing to partially resect the diaphragm, pericardium, or other adjacent involved structures for a truly total clearance. While aiming to improve oncologic outcomes, MTPD poses higher risks for complications due to its more extensive and complex nature. Patient selection is even more critical for this approach compared to standard EPD. For epithelial peritoneal mesothelioma, cytoreductive surgery, CRS, combined with hyperthermic intraperitoneal chemotherapy, HIPEC, is considered the treatment of the choice capable of achieving long-term survival in properly selected patients. In CRS, the goal is removing all visible tumor nodules throughout the abdomen and pelvis to leave residual tumor measuring 2 mm or less. This often requires multi-organ resection including stripping the peritoneum off affected areas with cautery or laser, splenectomy, partial gastrectomy, colectomy or extensive small bowel resection depending on tumor distribution. Once CRS is complete, the open abdominal cavity is perfused with a heated chemotherapy drug like cisplatin or mitomycin C using the HIPEC technique. The combined aggressive surgery and regional drug delivery has been shown to potentially double median survival times compared to chemotherapy alone. Patient factors like performance status, tumor burden, and ability to tolerate such an extensive procedure are important considerations for both CRS/HIPEC risk assessment and prognosis. For localized pericardial mesothelioma, radical pericardiectomy may provide the best chance for cure. Similar to other mesothelioma sites, this aims at a complete macroscopic resection with clear margins. As the pericardium is a thin sac surrounding the heart, this can usually be achieved through a median sternotomy incision without needing cardiac bypass support. For diffuse carcinomatosis or where resection seems unlikely to leave no gross residual, debulking pericardiectomy may still provide symptomatic relief but prognosis remains poor. Emerging evidence has demonstrated long-term survivors even for advanced stages when a R0, complete, resection can be accomplished with pericardiectomy for pericardial mesothelioma. With multimodality treatment including the above-discussed latest surgical techniques combined with chemotherapy and occasionally radiation, the median survival outcomes for carefully selected mesothelioma patients has steadily improved. However, mesothelioma remains an aggressive cancer requiring an experienced multidisciplinary team approach considering both oncologic and quality of life factors for each individual case. Ongoing research on biomarkers, novel targeted drugs, immunotherapy, and additional technological advancements may help further optimize surgical and non-surgical treatment strategies to potentially cure more mesothelioma patients in the future. Precision medicine incorporating patient-specific tumor genomic analysis also holds promise to personalize and improve current mesothelioma management protocols. The latest surgical approaches for mesothelioma aim at removing all visible tumor while preserving as much functional status as safety allows. Extended pleurectomy, decortication is preferred for epithelioid pleural mesothelioma. Cytoreductive surgery combined with hyperthermic intraperitoneal chemotherapy is standard for epithelioid peritoneal mesothelioma. Radical pericardiectomy can offer the best outcomes for localized pericardial disease. Improved patient selection and expert multimodality care involving surgery, chemotherapy, and other specialized treatment modalities have led to better mesothelioma prognosis in recent years, but it remains an inherently difficult cancer to treat due to late diagnoses and aggressive biology. Continued advancements are still needed to achieve curability routinely in mesothelioma.